me try and share my screen. Okay. So we have our index patient. So he's now 7 years of age. So he has HBSS, but he had established care at St. Jude at the age of 4. So we're unsure of his genotype because I don't think we've ever done it since he's been referred to us. And then he actually came maintained on hydroxyurea. And he was compliant based on the records when I looked back about 2 years ago. And along the way, we had started voxelotor, but he had failed 2 times due to poor taste as per the records with mom. And I think on his last or recent admission, we reinitiated the voxelotor, and he seems to be taking it okay at that point. So I just had a snapshot of to show how compliant he was throughout his course. I think he came to us around July, so that's on the far left, and his HBS quantification at the time was 70%, with his HbF quantification at 27.2, and he's been maintained between, I think, 25 mg per kg to 29.5 mg per kg of hydroxyurea. Recently, he had a little bit of a dip, and I think that's because there was intermittent compliance due to his admissions in hospital, and he did have a very long admission over the last month. So his admissions to date, so when he arrived to St. Jude, he had not had any admissions to any hospital. He didn't have any crisis. There was a concern that maybe he had priapism, but when we went into it further, we discovered that it wasn't like a intermittent priapism. He actually had like a behavioral which we had sent him to psychology to help. It seemed as if he had, there was a complex socioeconomic background, which was contributing to some of his behavioral features. So in November 2021, he had splenomegaly. At that time, he was found to have an anti-E antibody, and he did receive 1 transfusion at that visit. And then his next visit was in February 2023. So he actually had a good 1.5 years before he was admitted again. And this time it was for splenomegaly, and he had received 3 small aliquot transfusions. And then he was readmitted for a delayed transfusion reaction after that admission for the splenomegaly in February. So he's had about 2 vaso-occlusive crises in his lifetime. The first admission was pretty unremarkable, and the second one required ketamine infusion. He does have an active pain plan. And then he's had about 3 splenic sequestrations in the past 1.5 years. The first one in November 2021, which he required 1 transfusion. Then he had 1 in January 2023, and he had 2 small aliquot transfusions. And then in February, he received 3 small aliquot transfusions. In January, his spleen size was, I think, 6 centimeters. And so usually, I think at baseline, his spleen size was about 3. At least that's what's documented and what mom has verbalized to the medical team. And so we've been judging based on that. And so when he presented in January, it was even further enlarged and 6 centimeters. And I think we did get an ultrasound at that point to just confirm, because he's always had like this persistent kind of enlarged spleen. And then his hemoglobin also significantly dropped. And I think his baseline is usually around 8 prior to this. And so he had presented with a hemoglobin of 5.8. And then in February, a similar presentation where he had a significant anemia and his hemoglobin was 4.8. The spleen wasn't significantly enlarged compared to his baseline, but we did go ahead and treat him as such because he also had decreased platelets of 80,000. And then in April 2023, he had his splenomegaly performed. For his pulmonology history, he's only had 1 acute chest, and this was in the setting of a vaso-occlusive crisis. He did require admission to the ICU because he required high flow nasal oxygen, and then he also received a unit of packed red blood cells on that admission. He's had normal TCDs to date. And so after his second splenomegaly, he developed a delayed transfusion reaction. He was admitted because he came in with bilateral pain. It was more significant on the right knee, but he also had dark urine and fevers. He was significantly tachycardic and tachypnic, and his direct Coombs test was found to be positive, and his total bilirubin with direct bilirubin was increased from baseline and dramatically increased. I believe it was 7.1, and I do have a slide to illustrate that. We went ahead and started IVIG on day 1 when he was admitted. However, his
Can I pause for 1 second, Larry? I just want to add in, guys. So prior to this admission, he had a negative Coombs. On this admission, he ended up having a indirect Coombs for anti-JKB. Also, when we did do his hemoglobin identification, his hemoglobin A went from 20%, which was transfused at his previous submission, which was only 3 days ago. That was about 20-something%, and it was now at like 2.5%. So essentially, he was hemolyzing his transfused blood.
Yes, correct. So we gave IVIG, however, his hemoglobin continued to be low and he still had significant tachycardic and tachypnea. So we went ahead and continued IVIG for another 2 days. So he had 3 days of IVIG. We also started Epogen for 3 days, and we also started steroids with it was a pulse, and then we tapered. And then on day 4, because he had persistent hemoglobin, his iron, we decided that we were going to do iron sucrose infusion, and we did 2 doses of that. And we did try to give rituximab just because he had refractory anemia, and he continued to have an elevated bili, and his LDH was also still high. We decided to do rituximab. However, he had a severe drug reaction, and we had to stop the infusion. There was consideration to do obinutuzumab, but he seemed to have responded after about 7 days, and we held off. His management of VOC in that admission was as per any other management, and so there wasn't any escalation that we had required to do for him. And this just shows, if you look from left to right, his hemoglobin trends while he was admitted. So he came in on the 18th of February. Sorry, I believe he came in on the 19th. So he came in from the morning into this was a repeat hemoglobin, and it was 6.7. And then his hemoglobin continued to trend downwards. So he went to 5.3, 5.1, 3.4, and 3.5. And I think by seeing this, you can understand why we were so aggressive and we're trying to give as much support as possible to help with his anemia. His platelet counts initially were low and continued to downtrend. And so we do think that he did have a little bit of a splenomegaly at the same time, but he was also hemolyzing as well. And then this just goes hand in hand with his reticulocyte count at the bottom. And this just depicts a graph of how we had managed him through his admission. So on the February, we gave IVIG. The purple is the hemoglobin, and his platelet count is the red line. And then down below, we have our LDH in pink, and his total bili in also purple. And so you can trend those lab values with his IVIG and see that despite giving IVIG, and even when we started to give steroids, his hemoglobin was still continuing to be low or continuing to be declined. We did have his LDH becoming a little bit more stabilized, and there was a little bit downtrend after we started steroids on the 20th. In addition to that, we saw a downfall in his total bili as well as direct bili. And so not really sure which one was the effective culprit, or if it was just a combination at the time. So we had IVIG as well as steroids. I think we started to see him look better and feel better in that admission. His hemoglobin did dip again around the 22nd, and that's why we decided to do the iron infusion. And then we considered giving rituximab, but we were already 7 days out, and his hemoglobin was a little bit better, and clinically he was also better. But then he had that that infusion reaction, which we had to stop, and so he didn't get any further rituximab doses, and he seemed to have responded with IVIG steroids and EPO.
Yeah,
that admission.
The reason we considered rituximab for him was because we were at this point in time gearing him up for a splenectomy. And so with the idea that how severe his hemolytic transfusion reaction was, we knew he was going to need more blood for prior to splenectomy. So we wanted to prevent future hemolytic transfusion reaction. But he essentially anaphylaxed with bronchospasms as well as hypotension. So that's within minutes of starting the infusion. So that's actually why we held off and considered obinutuzumab for him, which is another CD20. But we did not get to that point.
And so he actually was discharged the day after getting the rituximab, but he represented on the March the 13th. When he was discharged, he continued to do well. His hemoglobin was stable.
Can I ask you one quick question before that?
Sure.
Did you ultrasound and measure his spleen at all during that time?
We did, and it was bigger compared to, I think, the very first ultrasound he did in like 2021.
And then did you ever identify the new antibody that he made?
It was a JKB.
JKB was the new one.
Okay, thanks.
And so
this, sorry, go ahead. This admission here, which was on the 13th, was just about a week and a half following his last admission. And this admission was for vaso-occlusive crisis. And we thought that this essentially, his crises were triggered by tapering of the steroids.
Correct, yes. So he presented with vaso-occlusive. So this was his second admission, I believe, for this. And then you can see that his hemoglobin was 11.2 and they were continuing to taper his steroids. He also, unfortunately, developed acute chest during that admission. He also had an ileus, so he was very ill and he had to go to the ICU for management. And we ended up having to give IVIG, and we gave a pulse steroids on top of his tapering steroid dose. And he was transfused at this state because there was consideration for splenectomy. We ended up doing the splenectomy later on in this admission and towards the end. So I think he ended up getting a splenectomy on the 31st. And he did receive IVIG prior to transfusion at that point. But we haven't done rituximab, and we never did the obinutuzumab prior to his last transfusion in preparation for that surgery. And since his splenectomy, because he was discharged on the 2nd of April, it seems as if he's been doing well outpatient, and we haven't had any concerns for like vaso-occlusive crisis or acute chest or even a transfusion reaction since that admission.
Yeah. So when we transfused him, actually, the last transfusion for the acute chest, as well as gearing him up for his splenectomy, it was done with phenotypically matched red blood cells. Because at this point in time, there was a concern that obinutuzumab, although CD20 directed, was never really used for delayed hemolytic transfusion reaction. And I was personally afraid to re-challenge him with rituximab. So the consideration from the blood bank was to try to use phenotypically matched red cells with pre-medication with IVIG and steroids. And that seemed to help because he has held on to his packed red cells by a stable, looking at the hemoglobin A percentage.
But hard to know, right? If he's actually just holding on to it because you match the blood better.
Yeah, that is the question we do not know at this point in time. And I don't know if we'll ever know, but because that's the question. If, let's say, by some chance he needs future transfusions, I don't want to jinx him, but if he has abnormal TCDs or needs a surgery for some reason and we have to transfuse him again, do we try to get phenotypically matched blood for him again and use that in future? Or do we desensitize him to rituximab or use one of the neurotherapies? And I'm open to suggestions from you guys.
I would always give phenotypically matched blood,
Okay.
especially in people who've had a DHTR. Do you not phenotypically match at baseline or just not for JK?
Not for JK. So he did not have a JKB initially, and so we were giving matched blood, but this one was essentially what we tried to do is, regardless of his antibody status, we tried to get as much null blood as possible.
Yeah, no, I mean, we've had a DHTR as well with a JKB because we don't prophylactically match except at CE and Cal. But I mean, I guess that would be my take is I would probably transfuse just phenotypically matched blood. He sounds like kind of a sick kid. So
yeah, and he was sick for a while. Thankfully, once we took the spleen out, he actually has done great, knock on wood.
And he's back on hydroxyurea, I assume.
Yeah, he's back on hydroxyurea, and his mom is trying with
Voxelotor.
Yeah.
And it was all when he got sick in the beginning of this time, it was with Voxelotor once he was taking it, or he got sick and then you put him on Voxelotor. I got confused on the box.
Yeah. So he's had what we thought was chronic hypersplenism because he's had good Fs, but his hemoglobins were on the lower end, like 7s to 8s. And so we tried Vox initially. He didn't like it. And so we just said, okay, you don't like it. I guess we're not going to force feed you Vox. But then after he got sick, we tried to start it again. He did take it for 3 or 4 days, but then he was just spitting it out. So we essentially stopped it. And then once he was readmitted at the last admission, the inpatient team decided just to start it again to try to decrease the units of our volume of blood he's going to need. So he's taking it for now. We'll see how long that lasts.
That would scare me about a kid who may take it, stop taking it. At least we've had issues with rebound afterward. I don't know.
So we'll see.
I wouldn't re-challenge with rituximab. That's just me. Others? JJ? Elna, what would you guys do?
Hi.
I don't think rituximab works that well for delayed hemolytic transfusion reaction. Or let me rephrase that. I don't know anyone that it's worked for. I haven't used it a lot, but I've heard a couple of these challenging cases where people have given rituximab and it hasn't seemed to protect them. I know it seems like it should work, but I don't think it works that well. So I'm not sure if it's worth going that route. The other possibility, if Voxelotor is not working well for him, kinase activator. Well, he might not be old enough yet, right? But one of those studies, they're open for kids. 50-50 chance of getting active drug, but they're good at raising hemoglobin. And you'll know. I mean, like they work pretty fast, but they aren't great drugs, I think, to start and stop either. If it's someone who's going to start and stop things, you need to think hard about that. And Voxelotor is probably a better drug for that than a pyruvate kinase activator that washes out quickly.
Gotcha.
So, yeah, to answer that, we do not use rituximab any longer. I think maybe they may have tried it a few years ago, and we haven't had good success with rituximab. We seem to use more eculizumab, especially when they're older than 5 and they're coccal and all of those, but we've had better luck with them. And I think Satish, Dr. Chonat, who does more red cell, may have a case series on that. I wish I had the reference, but most of the time now we do steroids, EPO, hydroxyurea, make sure the maximum dose of hydroxyurea whilst you're giving the EPO. And as long as you have the EPO on, you keep the high dose hydroxyurea, especially when they're in the hospital, and then do the eculizumab, and they seem to respond very well. But especially after he's had that kind of anaphylaxis, for a marginal potential benefit at best, I don't think I will do it. It's not going to be worth it at all. So if he does this again, try eculizumab.
Okay.
I haven't had great luck with either rituximab or eculizumab. If anything, I've had slightly better luck with eculizumab, but I have recently, the last 2 cases, and I feel like we've had more lately, and more de novo, where I can't find an antibody and don't know what's causing it. I'm blaming COVID, but that's just because it makes me feel better to say that. This just recently happened, and in both recent cases, they had really severe reticulocytopenia as well from hemolysis of retic counts. And what I found was most effective was the steroids and time, right? They got in the hemoglobins of 4s, lots of Procrit. I didn't restart the hydrea until their retic started coming up because their nucleated reds were in the 300s, but no retics, so they were destroying them. And I really found the steroids worked the best.
How did you manage the rebound pain? Because this is what brought him back. Was as soon as we dropped the dose, he was having pain crises, and we were only to go down to, we're weaning by 0.5 mg per kg every week, and every time we dropped.
Yeah, no, it's a really good question. So I weaned them in the hospital, and most recently, and I've actually sent both patients out on methadone because I'm not always convinced that, are they really rebounding from the DEX or because they were withdrawing from opiates?
Okay.
But this kid is 7, right? How old is he? He's 7?
Yeah, I mean, I've seen a good bit of opiate withdrawal that is just pain. That's all we see it as. And I took a protocol that Deepa Manwani did out of New York, where she has been weaning with methadone, and I've applied it to a few adults very successfully. The inpatient hospitalists think I've lost my mind, but that's okay.
No, you haven't. As a matter of fact, we are going to be sending out a survey to look at the number of physicians or providers, APPs and physicians who do withdrawal COWS scale. And yes, it is difficult to use the COWS scale because pain alone, we give you that tachycardia and everything.
Yep.
But right, it masquerades so much as all the pain. And so you're right, putting them back on a slightly higher dose of the opiates actually helps, because even with DHDR, they'll present with pain and you don't know when it is. And so, but I'm not sure, the question I was asking is how slowly did you taper the prednisone? Over how long did you taper it off?
What'd you do? I'll tell you what I did.
Well, so he got the 2 per kilo for 7 days. And so after he was discharged, our plan was to go 0.5 per kilo Q weekly. So every 7 days, just go down until it was off. That was initially our plan, but we only got down to 0.5 per kilo, and it was too bad that he had to come back in.
I'll say the other thing is, I really don't know if this makes a difference whatsoever, but I use DEX, and I used to use a lot of DEX, and now I don't use as much DEX, and I go from 10 to 5, and great, these are adults, right? But I 10 to 5 to 2.5, and they seem to do better with a wean of DEX in my experience, but it's totally anecdotal. I won't promise you that I have a reason for it. But I find I don't need as much steroid if I'm using DEX versus prednisone. Again, totally anecdotal. But we just had a patient who is a patient well known to Dr. Ugunshale, who has S beta plus and or SC, one of the two, and just a very, very complicated pain patient. I mean, calls clinic almost every single day, no matter what we've done for this individual. Has been on Suboxone, did well for a while. Anyway, put on manual exchange transfusions, and then just came in with a DHTR, which is really unfortunate. Can't find, what did it. In his case, he didn't drop that far. So he only dropped to his hemoglobin like the 8s, so nothing to worry about. But I'm just worried about the fact that now I can't transfuse him. I can't figure out what caused it.
I was actually thinking about him the other day. I was like,
It's your fault.
I was wondering because I think before I left, I was at the point it was like, what's going to be our next
Is
step?
that patient on voxelotor?
That patient, no, he has S beta plus or SC. His normal hemoglobin's like 12.
Yeah, he has SC.
Not Chris?
He's not on Criz. He's been on phlebotomy and hydroxyurea, and
He had what his father believed was a reaction to crizolizumab. So he was on it for a while, and his father and he both believed that his pain increased. And there was one time when he came in and he got it and he was admitted afterwards. So we stopped it just for that. But I mean, I don't know if that can be another option.
yeah, I really
yeah, because there's so much chronic pain that it's hard to say what is what. Yeah.
in that individual.
Yeah.
So you may have to have her come to Jesus again and say,
Had many.
sorry.
TC, psychiatry, psychology, you name it. It's a rough situation. And I saw the question, Kristen, you were asking about the Vox. I've seen it a couple of times, but that's the case we published on one patient who would go out of town for the weekend and forget all her meds. And she would come in with severe like hemolysis and heart failure and everything, drop her hemoglobins to the 4s to 5, sick as crap in the ICU. And then we get her back up and everything would be fine. She'd go home on her Vox, and then she did it again. Finally, I said, I'm not going to give you any more Vox because if you're not going to be consistent, obviously it's going to hurt you. But she was nice enough to repeat herself twice, so we really got to prove that it was the Voxelotor.
That's good to know. I'll look up the publication.
That was just a case report.
You need to tell when they're not taking it, the hemoglobin just drops.
It really does. I mean, it's not subtle. It drops and their billy goes up and their retic count goes up. But that was a great case. I'm sorry that we don't have another didactic today. I think these DHTRs are so hard. We've talked about putting kind of a protocol together that perhaps if we all use the same protocol, we could actually find out what works and doesn't work. So we've talked about doing that, and maybe something to bring back up.
Yeah, I mean, what we kind of, the most recent thing that I saw was the ASH guidelines. And that's kind of where we based this whole Rituxan on and everything. But it's very variable out in the literature.
Yeah. Agreed. But I could say, we could do the same. For 5 days, we do high dose EPO and steroids. And if they're not responding, we'll do, half of us could do Ritux and the other half would do eculizumab, and we'll just find out what happens.
Mm-hmm.
Something like that.
And I think we might sort of complement inhibition that might work better than eculizumab coming on board as well. I mean, that's another possibility.
Yeah, but I think it'd certainly be worth it.
C1 inhibition or something, higher up on the pathway.
All right. Well, thanks, everybody. Have a good rest of the week and enjoy the spring weather.
Thank you.